Good morning, everybody. Thank you very much for the invitation. It was very nice to be here, and I'm glad actually for two reasons to be in this conference. The first one is because I had the opportunity to catch up with good friends, Dr. Chinthaka Da Silva and nurse endoscopist Muditha Samarasinghe, who trained with us when I was a consultant at the Royal Free in London. And the second reason as well is, I'm glad to be here, is I had a notice that in your logo there is someone I know. And this is Hippocrates, the father of medicine, who lived in Greece 2,400 years ago. He was born in Kosa Island in Greece, and he passed away in Larissa, again in Greece. And where is Greece compared to Sri Lanka? We are, I think you can see that on the screen. We are on the southeast side of Europe, on the eastern side of Mediterranean Sea. And Greece is known for natural beauties, but mostly of the Greek civilization. I'm sure you've heard of Plato, Aristotle, Socrates, Alexander the Great, and I'm sure you know that this is the birthplace for democracy. Now, coming to the topic itself, I have nothing to disclose. And when we talk about chronic diarrhea, we need to bear in mind that two components. There's chronic and diarrhea. So chronic, as we know, by definition means that it lasts for more than 4 weeks. But as long as diarrhea is concerned, even nowadays, we have no clear universal definition, and that's a bit of a challenge, to be honest. We know that there's a discrepancy between the medical and the lay terminology and what people think of diarrhea. And the bottom line is that it refers to a decreased water holding capacity of the stool. Now, the commonest way to define diarrhea is consistency, and that means stool looser than usual, is the volume, and supposed to be less than 200 grams of mass in normal people, but anything above 200 grams is considered diarrhea in most countries, especially in the Western population. I understand it's a bit slightly different in Asian population. And frequency of more than 3 bowel motions per day can be defined as diarrhea. But it's much easier to have that visualized with a Bristol stool chart, as you can see here. So, in principle, diarrhea is type 6 and type 7. And how common it is? It is quite common, actually. In the Western countries, it's 4 to 5% of the population that have diarrhea, chronic diarrhea we're talking about. And it can be up to 10% in elderly population. Now, in Asian countries, it is prevalent 1 to 4%. And as you can see from the graph, it has a mortality which is not negligible. It is roughly 20%. And coming to what we've learned in medical school, pathophysiology, there is osmotic diarrhea and there is secretory diarrhea. Osmotic means that there is ingestion of poorly absorbed cations and anions, such as magnesium, sulfate, phosphate, or poorly absorbed sugars, such as mannitol and sorbitol. And we need to remember that neither the small bowel nor the colon can maintain an osmotic gradient with plasma. And on the other hand, we have secretory diarrhea, which can be due to net secretion of chloride and bicarbonate, or to net secretion of potassium, or to net inhibition of sodium absorption. And what is the biochemical differentiation between the two? We know from medical school again, we have the fecal osmotic gap. Normal fecal osmolality is 290. If the fecal osmotic gap is above 125, some people say even above 100 milliosmol per kilogram, then by definition it is osmotic diarrhea. And if the fecal osmotic gap is less than 50, then we have secretory diarrhea. And how we clinically differentiate between the two? Well, there are few ways to help us with that, but in principle, secretory diarrhea has higher stool volumes above than 1 liter per day. It is important to remember that it continues despite fasting, in contrary to the osmotic diarrhea, and it occurs at night as well. And coming to the pathophysiology of chronic diarrhea, there is a complex regulatory system of the intestine that integrates autocrine, luminal, paracrine, immune, neural, and endocrine systems. And all of these can interfere with permeability, transport, motility, and metabolism in the bowel. And what are the clinical classification systems of diarrhea? We know very well it's based on time course, acute versus chronic, on volume, large versus small volume diarrhea, on pathophysiology, as we heard, common secretory versus osmotic, epidemiology, common causes versus rare causes, and stool characteristics, and that's watery versus fatty versus inflammatory. And this is something we need to remember, both in the primary care and in the secondary care setting. So I think this is the most important slide, watery versus fatty versus inflammatory. Of course, there are some causes that overlap, and that means that not all causes of chronic diarrhea are strictly one or the other. But by definition, most of them can be categorized in one of these groups. And we have watery diarrhea that has 3 subgroups, and this is osmotic, when we have water retention due to poorly absorbed substances. Second subgroup is secretory, which is due to reduced water absorption. And the third group is functional, which is due to bowel hypermotility. Now, the second group is fatty diarrhea. And fatty diarrhea implies defective absorption of fat in the small bowel. And the third group is inflammatory diarrhea. Inflammatory diarrhea is usually presenting with blood and pus per rectum, implies the presence of one of a limited number of inflammatory or neoplastic GI diseases. And we have a lot of guidelines for chronic diarrhea. We have the American guidelines, the American Gastroenterological Association, the American Association of Family Physicians, the British Society of Gastroenterology, Asian Pacific, Japanese. There are a lot of guidelines. If you want my opinion, the best one and the most practical ones are the AAFP and the BSG guidelines. And let's come into the different causes of diarrhea. Again, this is a list of the causes of diarrhea. Again, 3 groups. We have, as we heard before, watery versus fatty versus inflammatory. And coming to watery, we have, as we heard, the secretory subtype. I'm not going to go into all of them, but the most important of them. So watery and subtype secretory can be, for example, endocrine, can be microscopic colitis, can be post-surgical causes. On the osmotic side, we have lactose intolerance. We have, for example, magnesium and overuse of other laxatives. And on the functional side, we have a very clear group of diseases, and these are functional diseases, predominantly irritable bowel syndrome. Now, second group is the fatty diarrhea. So fatty diarrhea can be related to malabsorption, such as carbohydrate malabsorption. Lactose intolerance, for example, is a good cause of that. I understand it's not very common here, but it's quite common in Western population. And then we can have diseases related to gastric bypass, to mesenteric ischemia, which are common causes as well in the Western population due to vascular disease. Small bowel bacterial overgrowth as well can present with fatty diarrhea. And we have as well diseases related to maldigestion, such as pancreatic exocrine insufficiency. And then on the third column, as you can see on the slide, we have the inflammatory diarrhea. Now, this predominantly means that we have white cells in the stool. And causes of inflammatory diarrhea are predominantly Crohn's disease, ulcerative colitis, diverticular colitis as well can sometimes be present. And then we have neoplasia, colon cancer, for example, lymphoma. We have radiation colitis, and this is a significant group, inflammatory diarrhea. And how we'll differentiate again between all these causes. So the critical first step is medical history. We need to understand what patients mean when they say that they have diarrhea, and again, there's a cultural background into that. We need as well to take into account that a patient may not actually have diarrhea, but they might have incontinence, which they present as diarrhea. We need to have a clear reporting of key stool features, such as appearance, odor, volume, frequency, consistency. And we need to ask the patient, is there any urgency, any tenesmus, any pain? Does it persist at night? Does it persist with fasting? Are there any possible triggers? Is there any travel history? And again, of course, common causes are common, but a bloody diarrhea after a trip to Africa, for example, may still be ulcerative colitis rather than amoebic dysentery. And we need to take a good drug history and a good food history. And this is a slide that gives us a better understanding of the importance of stool characteristics. I'm not going to get into detail, but just to give you an example, we might have hyperdefecation, which is quite common in the UK, which means that we have an increased frequency without essentially watery stool, and this is usually IBS. And on the other hand, with stool weight more than 200 grams per 24 hours, we can have, for example, carbohydrate malabsorption with or without steatorrhea. And coming to, again, to the American guidelines, these are the things we need to do in the primary care. So we need to include all systems examination. Does the patient have weight loss or lymphadenopathy? This might be related to chronic infection or malignancy. Is there episcleritis? This is usually related to ulcerative colitis or Crohn's. Is there exophthalmos? This is usually hyperthyroidism. Is there any dermatitis herpetiformis? This is usually related to celiac. Are there any abdominal scars? Of course, there are a lot of surgical causes of diarrhea. Are the bowel sounds increased? This probably means hypermotility. Is there any abdominal tenderness? This is most of the time is related to infection or inflammation in general. Are there any abdominal masses? This is usually related to neoplasia. Or we need to check if there's any anal fistula, which is usually Crohn's disease. And the list goes on. The physical examination is of paramount importance. Another way to give you a long list of symptoms and signs we need to check. I'm not going to get into all of that into detail. You can read of that. But I just want to highlight the importance of flushing, which most of the times means carcinoid syndrome. We need to check as well for right heart murmur or wheezing. And again, this is a symptom of carcinoid. Hepatomegaly, in the context of chronic diarrhea, always raises the suspicion of endocrine tumor or even amyloidosis, more rare causes, of course. And arthritis, in the context of chronic diarrhea, raises the suspicion of inflammatory bowel disease, Yersinia, or Whipple's disease. And the primary care assessment needs to involve as well digital rectal examination to exclude any mass, impacted stool. It needs to include office rigid rectoscopy, I know the resources are very limited in this country and in other countries as well. It's not, even in Europe, it's not always possible. But, you know, it is a very easy and straightforward way to investigate in the outpatient setting in an office setting whether there's any ulceration, inflammation, or neoplasia of the rectum. The patient doesn't need to have any preparation. Straight ahead, we stick a very rigid camera and we can tell it quite easily. And the other thing which is easily done in the outpatient care setting, in an office base, is the fecal calprotectin, which I understand, again, is not always available in all of the countries, but this is like a Western-type blot, like one of the pregnancy tests that we do, that can tell you whether it is positive or not. And what is calprotectin? It's an important marker. It's a protein derived from neutrophils and monocytes during inflammation. This can be found in blood, in saliva, in urine, in stool. A positive fecal calprotectin, by definition, means that the diarrhea is inflammatory. And we have values less than 50, which means calprotectin is normal. Above 150 micrograms per gram of feces, which means that calprotectin is positive, and we have the gray zone between 50 and 150. But again, there's a very simple test that can be done in the outpatient setting that it's not qualitative, it just tells yes or no, is it raised, is it positive, or is it normal, and that's very important. And we need to remember as well that as physicians, we prescribe a lot of medication. And you remember that one of the basic Hippocratean rules in the oath is, in the medicine is, make a habit of two things to help, or at least not to do harm, and we do quite a lot of times with all these drugs. Again, I'm not going to go into detail in all of this. Giving you some examples, we have magnesium containing antacids, which are quite commonly used, that can cause osmotic diarrhea. We have, for example, calcitonin antibiotics, such as augmentin, quite commonly used, or cardiac glycosides that can cause secretory diarrhea. We have metoclopramide and erythromycin that can cause motility-related diarrhea. We have acarbose for diabetes control that most of the times can cause a bit of malabsorption. And we have as well antibiotics such as, again, augmentin, amoxicillin, clindamycin, and antineoplastic drugs that can cause symptom membranous colitis. And that's the algorithm based on the British Society of Gastroenterology guidelines to tell us what to do in the outpatient setting. So, bloods, full blood count, CRP, thyroid, celiac serology. I understand celiac is not very common here. And then, as you can see on the box again, on the second line, on the second column, if we are highly suspicious of colorectal cancer or IBD, definitely we need to send the patient for a colonoscopy. If there is any concern about pancreatic lesion or pancreatic mass, we need to send the patient for a CT scan and an MR enterography, of course, if it is available for suspected inflammatory bowel disease. And as you can read at the bottom of this slide, if there is significant or if there's persistent, difficult symptoms, atypical, which we cannot solve in the outpatient office with all the set of investigations, we need to consider secondary care referral. And what the gastroenterologist will do, the gastroenterologist will take again a detailed history. He or she will repeat a detailed physical examination, and the gastroenterologist should be able to distinguish between organic symptoms based on the presence of alarm features versus functional symptoms such as the lack of nocturnal motions. The gastroenterologist should be able to tell whether it's malabsorption versus inflammation, and of course to remember all the long list of the causes we just mentioned. And the gastroenterologist, depending on the local causes that are more common or a bit more rare, will go through that list and will request, for example, a CCAT scan for bile salt diarrhea. Then the gastroenterologist needs to consider whether there is any previous surgery, to consider, for example, for small intestinal bacterial overgrowth and request specific tests for that, to see whether there's any history of abdominal surgery or previous history of inflammation, to consider about an undiagnosed Crohn's disease patient, and go through this list, and of course, think about the most rare causes as well. For example, neuroendocrine tumors. In that case, we need to check a full gut hormone profile and a urine 5-HAA. And I'm not going to get into detail about all of these diseases one by one. Let me give you just an example of the most important ones, in my opinion. IBS, quite common in the Western population. I understand it's becoming more common here as well. We have the Rome 4 diagnostic criteria that you can see on the right-hand side of the slide. It's got 3 subtypes: IBS diarrhea predominant, constipation predominant, alternating. And the IBS diarrhea type, it is the commonest cause of diarrhea in the Western world. It is functional, that means there is no inflammation, there are no noxious motions, and fecal calprotectin is negative. And coming to inflammatory bowel diseases, this is ulcerative colitis and Crohn's disease, which again I understand are increasing in prevalence as well in this country. Ulcerative colitis affects the colon only and the mucosa only, typically presents with blood, perirectum, bowel urgency, and night motions. The treatment consists of mesalamine, oral and topical, steroids, immunomodulators such as azathioprine, and biologics, including anti-TNF, anti-integrin, anti-interleukin 12 and 23, JAK inhibitors. While on the other hand, we have Crohn's disease, which can affect any part of the GI tract, can be transmural, typically presents with symptoms that depend on the location, either blood or without blood, diarrhea, of course, weight loss, anorexia, and more or less the treatment is the same as we heard above with minimal alterations. Bile acid diarrhea, again, this is a very common cause in the Western population. It's getting commoner, I understand, here as well. Most of the time secondary to ileocecal resection or cholecystectomy, and refers to excess of bile acid in the colon causing colonic irrigation. CCAT scan, which is a nuclear medicine scan, is the test of choice. I understand it's not easy to get it in most countries as well of Europe on a timely basis, but we can easily try an empirical dose of bile acid sequestration, such as cholestyramine, and see if it works. If it works, this confirms the diagnosis and you have the treatment. Microscopic colitis, that's a common type of watery, subtype secretory diarrhea with night motions, predominantly affecting middle-aged women, diagnosed with biopsies. And here's the importance, again, of colonoscopy. It has 2 types, lymphocytic colitis and collagenous colitis. Both of them should be treated with oral budesonide as first-line treatment. And again, to summarize in a different way, if we go to the diagnostic algorithm of the American Association of Family Physicians, which I find is very practical, you see that the first thing we need to do, we check whether it's chronic diarrhea, and then on the right-hand side column, the first thing we do, we check if this is inflammatory. Easy test, either white cell in the stool, or even better, calprotectin positive. This means this is inflammatory diarrhea, and we'll follow that pathway. On the left-hand side of this diagram, you see fatty diarrhea, and again, we need to check for causes such as pancreatic insufficiency or for example, autonomic defects. And in the middle, we have watery diarrhea, which is a bit more difficult to investigate. We need to calculate the fecal osmotic gap, And if we go on the left-hand side of this diaphragm, a positive gap above 125 is usually osmotic. On the right-hand side of this slide, you saw that you can see that if it is low, the fecal gap, we have secretory diarrhea, and if in the middle it is normal, we have, by definition, functional diarrhea, which means practically IBS. And with all that, I'd like to conclude saying that chronic diarrhea is common, and although most of the times we can easily diagnose it, sometimes it can be challenging to investigate. We need to remember watery versus fatty versus inflammatory diarrhea. We can get a gastroenterology referral for difficult cases, and we need to remember as well that fecal calprotectin and colonoscopy are the best weapons in the hands of the gastroenterologist. And with that, I'd like to thank you, just showing you two nice photos of remainings of nice civilizations on the top of a stone or a rock. Thank you very much.